Hello, everyone, and welcome to our webinar, 2019 MIPS Real Improvement Activities. All lines have been muted. The webinar will last 1 hour, and we will have dedicated time after the presentation for Q&A. If you have questions throughout, simply type them in the comments section, and we'll address during Q&A time. This webinar is being recorded and will be sent to all participants afterwards. Our speakers for today are Caroline and Katie. Caroline and Katie are MIPS assurance specialists at iCare Leaders who work with clients using the MyCare MIPS assurance program. Thank you for taking time out of your busy schedule to join us today. At this time, I will turn the webinar over to Caroline. Caroline?
Thank you, Teresa. Hello, everyone. This is Caroline. I'm going to give you an overview of the 2019 MIPS rule changes. I'll also talk about some common misconceptions on improvement activity and provide you with general guidelines for documenting improvement activities. My co-presenter, Katie, will present the iCare Leader short list of recommended improvement activities, and she will also go into the details on some specific improvement activities on that list. For the 2019 MIPS performance category, there are some few changes. And also CMS have changed the name for ACI to promoting interoperability. ACI used to be the new name for meaningful use. For this year, quality weighting will decrease from 50% to 45%. Cost weighting will increase from 10% to 15%. Costs include cataract episodic cost measure, which means if you have any provider that does cataract surgery, you have a cost score for this year. Complete patient bonus will continue at 5%. Small practice bonus has been moved into the quality performance category, reducing its impact, and improvement activity will stay at 15%. For 2019, the MIPS performance threshold and payment adjustment has increased. The performance threshold has increased from 15% to 30%. So which means for you to avoid a negative payment adjustment for this year, you need to get at least 30 points out of 100 for your final MIPS score. The exceptional performance threshold has increased from 70 to 75%, and the payment adjustment is for this year is plus or minus 7%. The nominal payment adjustment are misleading. The upside does not include exceptional performance bonus, but it is subject to a scaling factor, which is applied for payment year 2 years later. CMS estimate for 2021 payment year is maximum at plus 5.67% with exceptional performance bonus included. We are still within the 5 years of transitional scoring. The big picture over a 5 years time frame. Where are we? We are halfway through the transitional scoring and it's getting a little harder every year. Transitional scoring is characterized by having the performance threshold predefined and artificially low. PT means performance threshold, and that is equals to the MIPS final score for neutral 0% payment adjustment. The 2022 performance year will be hard. And this is because the performance threshold will be equal to the nationwide average score, which means half of providers nationwide will fail getting a negative payment adjustment. We won't even know the 2022 performance threshold until Q3 of 2023. In 2022, we will only have a CMS estimate of what performance threshold will be. Consequences of a low performance threshold. The good part is that a great majority of MIPS eligible clinicians will avoid a negative payment adjustment. And the bad part is that there is limited money available to fund the positive payment adjustments. This results in a scaling factor that brings down the maximum positive payment adjustments. plus 7% is expected to scale down to an estimated 1.60%. The exceptional performance or additional payment adjustment scales from plus 10% to an estimated plus 4.07%. Together, instead of a maximum of plus 17%, it scales to estimated to plus 5.67 for a perfect 2019 MIPS final score of 100. There's more money in play in 2019 than in the first 2 years of MIPS. An estimated 12.67% of your total 2021 Medicare Part B professional fees, service fee. For example, if your total will be $350,000, $44,000 would be in play due to MIPS. Now that's a lot of money. This scary looking graph shows the payment adjustments are not awarded linearly based on your score. The biggest payment adjustment will be for 2019 MIPS final score, close to 0 or 100. If you have an average score somewhere in the middle, you will continue to see very small MIPS payment adjustments. To really succeed and make MIPS work for you, you must be well into the exceptional performance range. At approximately for a final score of 80, you may get plus 2%. For a final score of 100, you may get plus 5.67%. For a final score of 60, you may get plus 1%. For a final score of 5, you will get a negative 7%. For a final score of 30, you will get 0%. That's a neutral score. The reporting period for this year hasn't really changed. Quality and cost, we are still required to report that for the full year calendar. Improvement activity and promoting interoperability, we're required to report that for at least a period of 90 days or longer. Reporting period may differ between categories. You can have a different 90-day period for improvement activity versus promoting interoperability. In other words, if you report improvement, you can report improvement activity for the first 90 days, and you can decide to report promoting interoperability for second 90 day or the third 90 days. But all improvement activity must be performed within the same 90-day or longer performance period. So in other words, if you're reporting more than one improvement activity, you should perform and document all your improvement activity within the same 90 days. We are required to report for MIPS either as a group or as an individual. So for improvement activity, we can report improvement activity as a group or as an individual. Group reporting means at the team level, data is aggregated across MPIs. Individual reporting means at teams or MPI level. Payment adjustments are always awarded at the team MPI level. Clinician may report as a group and individually within the same group. CMS will award the higher score. For group reporting, at least one provider must actively participate in improvement activities. And for individual reporting, that individual provider must actively participate in improvement activities. Group reported improvement activity does not cross credit for individual reporting. In 2018, there are some EHR related improvement activity that when we do that, we get up to 10-point bonus towards our PI measure. Unfortunately, in 2019, MIPS PI no longer include bonus points for performing certain EHR related improvement activities. But however, there are certain improvement activities which should help you improve certain 2019 MIPS PI measures. And my co-presenter, Katie, will present more details on that later. And there's few general misconceptions about improvement activity that I would like to clear out today. Improvement activity are the most flexible yet misunderstood MIPS performance category. Improvement activities are not measures, so that means they do not have thresholds. They are not just a state of being. It requires an active participation by at least one clinician. It does require documentation, and the practice is responsible for the documentation because you will eventually be audited. Those documentation will serve as a proof that you actually perform the improvement activity. Think of improvement activity as continuous quality improvement program. We can always do better. Use improvement activity as an opportunity to do something worthwhile to help the practice and patients. Group size. I want to talk about group size because it affects your improvement activity strategy. If you are a large group with more than 15 providers, you will need to perform 2 high weight or 4 medium weight or 1 high and 2 mediums weighted improvement activities. If you are a small group with less or equals to 15 providers, you only need to do 1 high weight or 2 mediums weighted improvement activity. Keep in mind that CMS evaluates the size of group on per teen basis, not for your practices as a whole. So that if you're reporting with 2 teens, CMS will look at each teen as though it were a practice on its own right. Group size is not based on the current number of providers, but the number in a prior period as measured by CMS. CMS will tell you for each of your teams if it qualifies as a small practice or a large practice. There's some misconception about improvement activity that requires the use of QCDR participation. There's a dozen of improvement activity that refers to participation in QCDR, but CMS guidelines are clear participation is not enough. You must use QCDR data for the underlying purpose of the specific improvement activity. QCDR stands for Qualified Clinical Data Registry. An example will be IRIS. Do not let your registry lead you astray. Reporting quality with a registry is not just enough by itself for you to claim the QCDR related improvement activities. For example, to claim improvement activity related to improving patient safety using QCDR, you should analyze patient safety issues using registry feedback or benchmark data. You should plan and implement a clinical change based on this data. You should analyze how effective that the improvement was, again using the QCDR data. At the end, you should document everything. Another improvement activity that we often have misconception about is the provide 24/7 access. This improvement activity is not primarily about the EHR. It requires extended patient access to care, not just providers access to the EHR. You can accomplish this in several ways according to CMS guidelines. The first one is by expanding your hours in the evenings or weekends. By finding alternate ways of meeting with patients, such as phone visits, or the doctor could visit senior centers or assisted living centers. Or the easiest option is to improve on same day or next day patient access to care for urgent cases. You could measure the percentage of time that urgent requests for eye care are accommodated the same day, the next day, or later than that. If you feel like those numbers needs improvement, then this is the improvement activity for you. Focusing on urgent appointment scheduling may be easiest option since it doesn't require you to change your business hours or finding alternate ways to meet with your patients. Also, I will be presenting some general strategy for performing and documenting improvement activities. We are eye care leaders. We recommend that you create a mission statement if you want to start documenting or performing your improvement activity. This is not a CMS mandate. Think of improvement activity as a quality improvement program for your practice. Don't just approach improvement activities cynically as just something to do pro forma to satisfy irritating government regulations. In other words, you just want to do it to get the 15% that's designated for improvement activities. Turn improvement activity into something positive. Make it count for something more. Use improvement activity to improve the quality of care for your patients. That way to make your practice even more successful as a business. Use improvement activities to improve your other MIPS performance measures such as quality, cost, and promoting interoperability. We also recommend that you form an improvement activity team, and this is not a CMS mandate. CMS only requires a participation for at least one MIPS eligible clinician for a group reporting, or participation by an eligible clinician reporting individually. Who should be part of this improvement activity team? The practice admin or delegate, the active participating MIPS eligible clinician, the assistants such as the COAs to provide a complementary service, a complementary perspective. If you have signed up for a MIPS assurance service and we have assigned you to a MIPS assurance specialist, take advantage of the specialist. Pull in your MIPS assurance specialist to be part of your improvement activity team. Brainstorm with your MIPS assurance specialist. Also, you can pull in other resources as needed, such as your billing team, front office staff, scribes, photographers, your IT team, and other physicians not actively participating. We also recommend you document meetings with structured minutes. And this should include the meeting date, the participants, so who attended the meeting, the agenda discussed during the meeting, the topics covered, the action items. The action items such as the who, the when, the what. The who should be who is responsible for carrying out the action item. The when do we need this action item accomplished? The what should be the action item itself. Meeting minutes goes in your MIPS audit file. They will help you prove when you start the improvement activity that year and also which physicians were actively participating. You should plan and document your improvement activity. CMS improvement activity are just a topic, but you plan a specific approach for improvement on that topic. Measure what you want to improve before you try any clinical process changes. Measure again after you implement changes. Include all these measurements and analysis in your MIP audit file. You can repeat the same activities the following year, but you need to have room for improvement. In other words, you can repeat the same improvement activity only if there's room for improvement, because you want to always think of continuous quality improvement. Avoid repeating improvement activity which will give you diminishing returns. At this point, I'm going to switch over to Katie, and Katie will present us with the 2019 update on improvement activity list.
All right. Thank you so much, Caroline. So everyone, my name is Katie Buchholz. I am a COA on the MIPS Assurance team, and I'll start my part of the presentation by focusing on the CMS list of improvement activities and the 2019 updates. So let's provide a bit of background on the CMS list of improvement activities. Every year, CMS updates this list. Activities are modified, added, and retired. This year, 118 improvement activities comprise this list. That's a really high number of activities to sort through and decide upon, right? So to help you out, iCare Leader's MIPS Assurance team actively curates what we affectionately term the short list of improvement activities. It contains improvement activities that we have found are well suited for iCare. We then divide that list into two parts, highly recommended and also recommended. The difference between the two is that the highly recommended activities are exceptionally applicable to eye care for MIPS 2019. The also recommended activities, while still very helpful, may not provide as much strategic value for the year. This is our highly recommended list for 2019. To explain this list a bit, let's go over the subcategory names for the activity IDs on the left side. When you see the letters IA, it stands for, obviously, improvement activity. BE is beneficiary engagement. CC is care coordination. And EPA is expanded patient access. Drawing your attention to the right side of the screen, you'll also see the weights for each activity. As you'll remember from Caroline's presentation earlier, for 2019, practices with less than or equal to 15 providers require 1 high weight or 2 medium weight activities. If you're in a practice with greater than 15 providers, that requires 2 high weight or 4 medium weight or 1 high weight and 2 medium weight activities. Now, the temptation here is to pick a measure because it's listed as a high weight measure. Make sure that it will truly help improve your practice when you choose it. Now, looking at the center of the list, the names. We have patient surveys, use of specialist reports to close the referral loop, regular training and care coordination agreements, improving bilateral exchange of patient information, and provide 24/7 access. Why do these activities merit the highly recommended list for 2019? Well, let's look at all of the care coordination activities first. There is a natural synergy between critical MIPS promoting interoperability measures and the care coordination improvement activities. No matter your practice size, even if your practice has more than 15 providers, you can technically focus all of your improvement activity efforts on care coordination by using 2 or 4 medium weight care coordination activities. Now, the non-care coordination activities that made the highly recommended list are patient surveys and 24/7 access. Here's why. Patient surveys, they provide a good metric. And do them while you can, because in the future, they may be cost prohibitive. CMS has been threatening to require that all surveys be performed by certified survey vendors. And unless you have a lot of extra cash lying around, that requirement will basically torpedo the patient survey improvement activity in the future. And last on this list, we come to providing 24/7 access to physicians. Caroline discussed earlier that this activity has historically been a bit misunderstood. We will look at some practical applications for this that reflect the true nature of the topic. Now, let's look at the also recommended portion of the 2019 shortlist. Remember, these are the honorable mentions. They have great eye care applications, but like I said earlier, may not provide the greatest benefit for you in 2019. First of all, we have some new subcategory names. AHE stands for Achieving Health Equity. PM equals Population Management. And PSPA means Practice Safety and Practice Assessment. Just like on the previous slide, we have the activity weights on the right-hand side. And now for the names. First, we have new Medicaid patient engagement. This activity can incorporate nicely with Provide 24/7 access, and we'll talk about that later. Comprehensive eye exams. This one is new for 2019, and it's the first improvement activity that focuses specifically on eye care. It's not what you might think it is, though. More on that later as well. Also new for 2019 is the Financial Navigation Program. This could be a really good activity, for example, if you're, say, a glaucoma specialist who has patients who struggle to afford their glaucoma drops. Next up is timely communication of test results. Perhaps you're an oculoplastic specialist and you do a lot of biopsies. This one might be one to consider. Next, use of QCDR, Quality Clinical Data Registry, for example, IRIS, to improve your patient's care coordination. There are actually about 12 to 13 improvement activities on the CMS list that focus on leveraging your QCDR. Word to the wise, though, it's not enough to merely participate. You have to use the data from the QCDR. Then we come to documentation improvements and medication management improvements. There's registration in a PDMP, which is a prescription drug monitoring program. Note that in this activities definition, you have to query the PDMP, and it's not enough just to register for it. Also recommended, patient safety tools, clinical decision support, and finally, leadership engagement. The latter may be an excellent choice for larger practices with more management tiers. You could consider having, for example, a member of the executive team, quote unquote, sponsor the improvement activity implementation team. All right, moving forward, let's dig into the highly recommended list. And we'll start with the improvement activities that emphasize care coordination. So, what is care coordination? Think of it in terms of the referral process. CMS likes to call this process referral loops. Honestly, when you first come across it, it's a bit confusing, but we'll get this all cleared up. So here we go. If we break down the referral process, we discover that there are essentially two different referral loops. Different parts of the loop involve different measures from 3 of the 4 categories that make up a MIPS final score. Depending upon the nature of your practice, you may have greater patient volume in one referral loop over the other. A very large practice with a microcosm of different specialists may not have as many referral loops consisting of physicians outside the practice. These loops may occur more in-house. Let's examine the chart in terms of us being a general ophthalmologist in the center block. First, we're looking at referral loop number 1. A patient is referred to us, and the summary of care file comes to us via direct messaging. We need to receive the message and put the health information into our electronic medical record system. That process accomplishes a 2019 MIPS promoting interoperability measure. To continue with referral loop number 1, now we've seen the patient, and it's time to send an e-fax or a letter back to the referring physician. If we need to improve this part of our process, we can think about choosing the highly recommended improvement activity IACC1, which is use of specialist reports to close the referral loop. More on that activity later. And now for referral loop number 2. Say we have a patient who needs to see a retinologist. We send our summary of care file to the retinologist via direct messaging. This part accomplishes a 2019 MIPS promoting interoperability measure. Once the retinologist has addressed the patient's problem, he or she sends the patient back to us by sending an e-fax or a letter. When we receive the specialist report back within 30 days, that accomplishes a 2019 MIPS quality measure called Closing the Referral Loop Receipt of Specialist Report. Let me draw your attention to the top right of the slide. There is another highly recommended improvement activity that will assist us with the first parts of both referral loops. It's creating care coordination agreements. More on that in a bit as well. So hopefully that helped you to understand the 2 different referral loops that occur in eye care. Now, why is that important? One of the 4 MIPS categories, the MIPS PI or Promoting Interoperability category, has received a massive overhaul in terms of calculations and content for 2019. If you look at the 2019 MIPS PI measures, you see that 2 of the measures depend on direct messaging. The other measures for 2019 have pretty well-established workflows. We've been doing them for years. We anticipate the 2 health information measures, though, will be the difficult ones. Why? Well, lots of practices have mentioned that there's a lack of referring or referral physicians in their area who use direct messaging. In addition, the weight of those 2 measures constitute 40% of your MIPS PI score. Also, because there aren't any hardy bonus points available in the PI category for 2019, Our success at direct messaging becomes critical if we want a high MIPS final score. So what can we do? Well, there are improvement activities that focus on care coordination. Please think about doing care coordination activities that will improve your results in other MIPS categories. Not only that, but we strongly recommend starting any of these care coordination improvement activities early in the year. Doing these early will lay a strong foundation for the MIPS PI measures that need the most help. As mentioned earlier, one of these improvement activities is the care coordination agreements. So this is essentially where both parties in the referral loop process agree to make direct messaging work. So let's look at that particular improvement activity. What's the CMS definition of this activity? It's to establish effective care coordination and active referral management that could include one or more of the following. Establish care coordination agreements with frequently used consultants that set expectations for documented flow of information and MIPS-eligible clinicians or groups between settings. This also includes providing patients with information that sets their expectations consistently with the care coordination agreements. Track patients referred to specialists through the entire process. And/or systematically integrate information from referrals into the plan of care. We recommend that if you choose this activity, don't just work on one aspect. Work on all three aspects. Why? Well, this provides a more comprehensive approach to improving a system that may need significant attention in the practice. Don't do improvement activities at a minimum level. Make them truly improve your practice and, let's be honest, ultimately improve your bottom line by improving your MIPS final score. Well, what steps can we take to implement this improvement activity? First, analyze your top current referring physicians and referral partners. Focus your efforts there. Next, agreements, by their very nature, are more like contracts. So if you have a lawyer for your practice, consider having them draft a simple template for you. What do you put in this document? We'll look at that on the next slide. So moving on, now you have the care coordination document finalized and back from the lawyer. What's next? Contact your outside practices and begin an administrator-to-administrator dialogue, and then send out the care coordination agreements to them. Well, some say, what's direct messaging? Or, no, I still prefer to send referrals on stone tablets. Sure, you'll have those. But you may find that in order to garner as high a MIPS final score as possible, we may need to think about that referrals will now need to be balanced between a clinical decision and a business decision. Your MIPS final score will increasingly have bigger impacts on your practice's bottom line. Now, moving on with my list here. Finally, monitor and document the improvement activity success via related MIPS PI and quality measures. Remember on our last slide that there is a synergy between the improvement activities and the promoting interoperability and quality measures? There are dashboards and registries that provide data feedback that you are already using. Use those metrics that are already in place. Now, let's go back into detail and revisit items to consider including in a care coordination agreement template. What do we tell the lawyer to put in this template? They, of course, will figure out the specific words, but we want to establish the content. Well, let's think about administrative points of contact for each practice. In case questions or issues arise in direct messaging, we think it makes sense to request administrative, IT, and clinical points of contact from your referring providers. But you could simplify it and just request contact information for one point person. Also, set a clear goal of making direct messaging work between the two practices. Make a clear commitment to test the electronic exchange and bring it to an operational and useful state. For example, what health information would be beneficial for both parties? How about a timeliness goal? With co-managing cataract surgery patients, consider including in the agreements that the co-managing physicians must send post-op reports in specific timeframes. These are all things to consider including in your care coordination agreement template. Now we're going to do a deep dive of another care coordination improvement activity, IACC7, which is care coordination training. If we're going through the effort of establishing solid workflows to improve the troublesome MIPS PI measures, use this as an improvement activity. Here are some approaches to consider. Establish a training plan, even if it's very high level. Provide general training on referral loops and the process behind care coordination between practices. Basically, let's make sure that everyone as a staff is speaking the same language. We can also provide training on workflows for your particular EMR. Make sure everyone is using the technology correctly. For example, one of the things that we've started offering with the MIPS assurance clients is providing staff training sessions on these workflows. We then document the training session, the content, the date, and the attendees, and include that in the 2019 MIPS Improvement Activity Audit file. There's also another highly recommended improvement activity in care coordination called bilateral exchange of patient information. CMS's definition is that this activity works to ensure that there is bilateral exchange of necessary patient information to guide patient care that could include one or more of the following: participating in a health information exchange if available, and or the use of structured referral notes. Structured referral notes are the same as summary of care documents. Some approaches to consider: send and receive summary of care documents for referrals. This would be for referral loops with direct messaging. Again, focus on making it work. Another approach is to participate in a health information exchange or of summary of care records as an alternative to direct messaging. So why choose this improvement activity over the creation of care coordination agreements? Well, maybe you don't want to involve a lawyer in making the agreements. This is also a good activity if you want to specifically focus on improving the functionality and content of your referral notes. You could also use this activity to segue into setting up care coordination agreements in the future. On to the specialist reports improvement activity, yet another highly recommended one. This activity is a good example of how CMS intended the improvement activities to be a topic, not merely a measure. We see here that this is a broad topic, but depending upon your situation, you can approach this improvement activity from different angles. For example, a very basic approach is that if you're not using your EHR for specialist reports, why not phase in the use of letter templates? Well, what if you're already doing that? Well then, perhaps consider measuring the percentages of referrals for which you actually send specialist reports, or also the percentages of those reports that are sent within 30 days of the referral receipt. The numbers may not be as good as you think, and you could focus on improving those percentages. All right, say you're doing really well at those two items. Let's review the letter templates with the entire physician team. You could examine the aesthetics of the document. Do we need to include logos? Do we need to update our physician lists? Have we moved recently and we need to update our address? You could also examine the content. Is noting a patient's bunion surgery from 10 years ago really relevant to my referring physicians? If this analysis identifies significant improvement needs, your improvement activity should be to create improved letter templates. Finally, the most sophisticated approach to this improvement activity is to survey your referring physicians regarding how useful your letter templates are to them. Would they like to see different information? Or perhaps a different layout that is more conducive to quickly scanning the document for pertinent case information? Do we need to address the timeliness of sending summary of cares back? We can aggregate the survey results, change what's needed, and then resurvey the referring physicians to see if the change was helpful. Speaking of surveys, let's look at the improvement activity for patient surveys. Like I said earlier, do it while you can. For right now, we can continue the use of lightweight survey processes. We can use free survey services or even use a paper survey administered by front office staff. We want to design our survey around a topic that may be in need of improvement. For example, an age-old favorite is a survey about wait time. What do we do then? Well, we create a limited number of open-ended questions for our topic. We tabulate, analyze, and document our survey results in our 2019 MIPS Improvement Activity Audit file. Then, once you've done this, take documented improvement action based on your results. Finally, re-administer the survey to determine if it was successful. And then, don't be afraid to try something and fail. If it isn't successful, try something else. If the improvement activity is still around next year, you can keep the same topic, but just choose a different approach to correct the issue. Our final highly recommended improvement activity is 24/7 access. This one speaks to the basic business model of seeing patients and getting paid for doing so. The activity, though, as we mentioned, is frequently misunderstood. It's not merely having physicians who can access their EMR outside of normal business hours or off-site. In addition to that, we can pick one or more of the 3 approaches outlined by CMS. So we see here that you could consider providing expanded hours in evenings and weekends. Another option is the use of alternative access to care, such as visits at alternate locations. Could we consider senior centers and assisted living centers, for example? Well, what would most likely be the easiest would be to focus on same-day or next-day appointments for urgent care. So how do you do that? Think about this. Document and analyze your current success for urgent appointments. Once that's done, design, implement, and document changes in your practice to improve this. And finally, reassess and document your findings to determine how effective your changes were. Practices that have greater than 15 providers. If you choose this activity and you need another high weight, think about engagement of new Medicaid patients and follow-up, which is activity ID IAAHE1. That's on the also recommended list. Then, with those activities, you could focus on improving appointment scheduling for urgent care appointments with emphasis on Medicaid patients. Okay, last improvement activity to be discussed today. Comprehensive eye exams. Very interesting because it's the first improvement activity specifically tailored to eye care. So why is it on our also recommended and not the highly recommended portion of our improvement activity shortlist? Well, the measure isn't merely about providing comprehensive eye exams. It's also intended to promote the importance of eye exams. This can be accomplished by providing literature or also facilitating conversations about this topic, using resources that are already in place. For example, the Think About Your Eyes campaign and or referring patients to resources that provide no-cost eye exams. The AAO and AOA both have such resources. Well, who is this activity intended for? It's intended for non-eye care physicians who refer patients to optometrists or ophthalmologists and optometrists caring for underserved patients at no cost. That's all the direction that CMS gives on that one. Or any clinician providing literature and or resources on this topic. The target beneficiaries of this activity are underserved and or high-risk populations that would benefit from discussions about their eye health with the goal of improving their access to comprehensive eye exams. So, how does this apply to you? Well, if you choose to consider this activity, think about educating underserved patients regarding the importance of comprehensive eye exams. You could also take it a step further and consider providing no-cost eye exams. There are existing programs in which you could participate. Also, our interpretation is that you could reasonably claim this activity if you provide free educational services and resources to the community. Well, why should you consider choosing this activity? While it may not have the strategic values of improving your MIPS promoting interoperability score for the year, improving appointment scheduling for urgent cases, or using surveys to improve your practice, this activity definitely has value. So, what could motivate you to choose this? Think back to why you went into eye care in the first place. It was probably because you wanted to save vision and reach underserved patients. Another reason to choose this measure is that you increase patient volume by bringing in those underserved patients. Also, through participation and outreach, you gain a positive image in the community. Well, what are some ideas for practically applying this activity? AAO's Eye Care America and the AOA Foundation's Infancy programs have volunteer opportunities and established infrastructure to provide no-cost eye exams. You can also consider educational outreach within your community. For example, could you set up a table at a local community health fair? You would bring some basic portable screening tools, educational information, and business cards. You can also consider visiting senior centers and doing the same thing. Well, where can you obtain educational information? AAO's Eye Care America website has an email link to request free brochures, bookmarks, risk factor cards, and tailored media templates for organizations and individuals who help those in need of eye care. All right. Well, thank you everyone very much for taking the time to attend today, and I will turn this webinar back over to Caroline.
Thank you, Katie. So I'll be providing with our today's takeaway. The fundamental challenge of MIPS affecting solo practitioners and small practices has not gone away. In 2016, for the first MIPS proposed rule, CMS was required to do an impact analysis. The results were shocking and are summarized in this table. 87% of solo practitioners were expected to fail MIPS in the sense of receiving a negative payment adjustment. Close to 70% of small group practices with 2 to 9 physicians were expected to fail, and close to 60% of group practices with 10 to 24 physicians were expected to fail. On the flip side, 81.3% of enterprise-sized practices or clinics with 100 plus physicians were expected to succeed with MIPS in the sense of getting a positive payment adjustment. The public comments were ones of outrage that it appeared the government was trying to drive solo practitioners and small group practices out of business and was trying to drive aggregation in the healthcare industry. Eye care leaders recognize that ophthalmology and optometry is naturally organized into small practices distributed throughout small and large and even tiny communities nationwide, and that the CMS prediction was due to an economy of scale issue. Enterprise-sized organizations have the economy of scale to afford a quality department, an IT department, a regulatory team, and a CEO to put all together to make sure they succeed with MIPS. Otherwise, heads will roll. This is why we at Eye Care Leaders introduced the MIPS assurance service to allow small practices to outsource MIPS to an expert part-time resource and achieve that economy of scale. With our roots as a software company and a SaaS business model, and the meaning of SaaS is software as a service. Eye Care Leaders' economic interests are aligned with our clients. We need you to be successful as a business 5 years from now and 20 years from now. We can't have MIPS drive you out of business. That's why we introduced the MIPS assurance service. You may think that since CMS made special accommodation for small practices during the MIPS transition years, you succeeded, perhaps with a perfect score for 2017 and 2018, that you don't have a problem. Don't be fooled. MIPS is getting harder every year. And by 2022, guaranteed, Approximately half of all providers nationwide will fail MIPS. Do you think those will be provider in enterprise-sized organization? Will those CEOs allow their organization to fail? No way. Also, did you notice that CMS dropped the most important 2018 accommodation for small practices? That is the 5-point bonus for small practices at the final score level. This puts you at risk. That's our takeaway. Be ready for MIPS to get much harder and consider outsourcing. Thank you very much for attending our presentation on improvement activities. And it's been an honor for myself and Katie to have this opportunity to give you this information. Learn more on MIPS webinar. The next one will be coming up in Q2, and it will be on surviving MIPS audit with proper documentation. Laura Roth, the Director of Certification, will make sure you know what to do. I'm going to turn this over to Teresa.
Thank you, Carolyn. At this time, we would like for you to invite you to register for our ECL Summit. There you can find out more and get your MIPS questions answered. Right now, we're having a special bring 3 or more staff and get a $50 rebate off each registration. Next slide, please. Also coming up in February on the 26th, we have a webinar with Tatiana and Dwight. They're going to be talking about utilizing TSYS for MyCare payment processing and DMA for MyCare statement processing, how you can save time and money. They're also going to talk about best practices to facilitate revenue flow and the importance of working with integrated solutions and much more. So be sure to register for that webinar at icareleaders.com/webinars. Do we have any questions from today's webinar? I'm looking. We don't have any questions at this time. So this concludes our webinar. This is a reminder that a recording will be sent out within the next few days. Also follow us on Twitter at iCareLeaders for summarized tips and action items from today's webinar. Thank you for joining and have a great day.